And in order to be compliant with everything that had to do with the social distancing and all the recommendations, the majority of the medical schools worldwide had to transition their curriculum online. And it was like in a matter of a few months. So there wasn't much planning ahead. For those that didn't already have it, the ones that didn't really had a tough job before them. Most of the clinical rotations were passed. The lectures and everything went online. We had so many webinars coming out. Some even were kind of like at the same time, the same day. So it was quite complicated. Everything that was surgical for many practices, in the sense that the students had to be able to attend the surgeries and so forth, they were also deferred because only urgent surgeries were allowed. And the examinations, we started to have examinations online in those places or countries or cities that weren't used to it. Now, postgraduate training also had a very important impact. And in saying this, many of the residency and fellowships were actually allocated to do COVID treatment. So in this sense, it really impacted negatively. We're talking about two cohorts, two generations of residents or fellows that had their time to dedicate themselves, for example, to ophthalmology, to refractive surgery, that in many cities and many hospitals were allocated to treat COVID patients. So having taken this into account, which is today's reality, but nonetheless, refractive surgery is still very hard to access on a fellowship basis. And even a residency training basis for ophthalmology. There are many places where there are not enough positions open so that a person could get a high quality education program. So let's talk about teleeducation. And when we use the word tele, we're also very accustomed to thinking about telecommunications, right? But it's the use not only of the telecommunication component, but of the informatics to be able to teach, to learn, to supervise, specifically when both the educator and the learners or the trainees are separated. They're not the same location. And this can obviously be done at any type of level. We're talking about undergraduate, grad, or even continuing medical education. And now, today, there are many subspecialty or specialty associations that already have their policies in place in order to favor and support online or remote education. And you can use either asynchronous or synchronous components. It really doesn't matter because it really depends on the scope of what you want to accomplish is the type of technology or learning vehicle that you're going to use. And this is just a small tribute to those that were really pioneers back in the 90s. This was in 1998 for those that may have been there and remember video refractive. Roberto Zaldivar, my mentor, and who we started all this movement back in the late 90s about being able to enhance not only our patients' outreach, but be able to educate those that just didn't have the possibility. He hosted 7 live surgeries for training purposes for ICLs. So we're talking about 1998. We're talking about fake KOLs back then. And we're talking about having live audio feed between the surgeon and the different audiences that were mainly in Milan, but the RAI took the signal and transmitted it to other 10 countries. And you're seeing the technology that was available at that time. We were using microwave to be able to get up to the satellite and be able to go all the way over to Italy. And we're seeing how our OR, we had to accommodate with cameras and with all type of technology at that point in time to be able not only to see the surgery, not only to be able to talk to the surgeon, but also to be able to exchange the clinical information about that patient that helped the trainees and anyone, the attendees, be able to understand why we were trying to accomplish what we were doing. So the basic goals of using ICTs in order to be able to enhance our educational process is about increasing access. It's about facilitating actually the knowledge that we all need. It's about being able to improve our decision-making processes, about improving overall our psychomotor skill coordinations. And this is about, and I'll say this many times, and maybe Dan just led us to that question, is accelerating our learning curve, but in a risk-free environment. Think about the aviation. This is not new, but it may be new to us. And it's about sustaining online engagement, about not getting bored, about being systemic in our approach, and about being consistent. It's about even being able to practice for rare and critical events. And overall, it's about increasing surgical collaboration and education among different academic medical centers around the world, or with the partnership of all these centers and all these wonderful colleagues that have preceded me and have already done so. So teleeducation, and specifically in these 2 last years, we've seen them grow so fast in these areas. First of all, it was about telemedicine. How could we actually outreach to our patients who were no longer coming in? Or if we were isolated, how could we better attend them? And it's about telesurgery, about telerehab, tele-ICUs. That was a whole different ballgame. We didn't have enough specialists globally speaking to be able to intake that surge that COVID actually brought onto everybody. It was about chronic disease management. All those patients that could not come in, how could we better trying to be able to see them and to be able to attend their needs, about remote patient monitoring and behavioral health, which has explosively grown. So for the sake of time, I won't go into much into telemedicine training, but I would like to say that if we don't understand the why we're doing things and how we can actually maintain our not only patient-doctor relationship and the privacy, but the quality of care, regardless of the medium we're using, well, we just don't know how to be able to come ahead and take on the challenges that we have today in modern society. And so now if we go into telesurgery specifically, because we're narrowing in into refractive surgery, it's obviously the use of wireless networking, robotic, and all the immersive technologies we have today to be able to teach and proctor, just like you've been seeing all these examples, but you've been seeing them live in person. I am now challenging you all to think about how can we enable our mentors and our trainees to be able to connect in a collaborative but virtual environment. So we always have to think about, like, for example, if we're talking about healthcare, where your electronic medical record is the foundation of your health information system. If we're talking about an educational information system, you have to think about an LMS, the learning management systems. And those today need new approaches and need new tools. So we have to think of a micro-learning design approach. That's the first step, because this is completely different. This is not sitting in a classroom for 45 minutes. This is about on-demand access to knowledge and being able to get skill transfers or cognitive competencies. It's about having a multimedia library of resources that can help you and aid you best in self-studying. It's about being able to access asynchronous lectures or classes, but also having live discussions, interactive mural posting. It becomes so much more fun to be able to do that. It's about also having your faculty synchronously with you, working and supervising your training encounters. And now it's even about serious games. It's about turning your learning environment into a gaming environment, which actually makes it not only more fun, but much more engaging. And it has the analytics that will help you track your performance. It's about 3D simulations, virtual reality, and also about the possibility of being able to debrief what you've learned, about being able to access online formative assessments, about being able to have accredited certifications, and once again, the learning analytics that will help us all. So serious games are something that are really coming up, and even though they haven't had an enormous impact yet in medical healthcare trainings per se, they have been now. We have more literature coming out on what they're gaining and what they're impacting on patient uptake, for example, in chronic disease management and being able to do treatment compliance and everything. It has been shown that it is very helpful for training. Now, think about the aviation once again. They're used to the simulators, but the simulators do have a cost. They're still cost prohibitive in many parts. But if we do gaming, and if it's on a browser, or we can download onto any one of our devices, and we can be wherever we are, and we're actually accessing the content, and we have different types of ways that we can do that fun. But obviously, where the trend is and where there is a lot of investment going forward is in the immersive technologies, whether they be 3D simulations, web-based, haptic simulations, which are the highest fidelity because you're feeling, you're sensing the pressure, even the temperature. If you're talking about augmented reality or the full immersive virtual experience, these are all the things that are enabling us to be able to interact with what we're doing, and they really are making an impact on the velocity that we can actually gain those competency and those skill transfers. So once again, this is a very different approach to our traditional or classic model, that's just Dan said, about how do we learn. It's about learning by doing and bridging that gap that we have between theories and practice, but in a realistic surgical environment, risk-free. Imagine the amount of times that you can actually, for example, break a capsule and then, or have different types of complications and then just go over them again and go over them again until you really are knowledgeable as to how to be able to better cope with those complications. And you're not on a person, and you're not consuming material, and so it's bringing down the cost, it's optimizing the resources that we all have available. So it gives us a standardized approach. Once again, it's trial and error, and it's risk-free. It's resource optimizing because you don't need as many mentors. You don't need as much room or space for all the simulators, for example. Now we have the virtual headsets that we can use also. It has clear metrics and algorithms that are being built in. And this, what exciting thing could be if we're talking about a collaborative and global setting. Now, we do have the challenges. The challenges educators are still thinking about, and this is also published, they're talking about compromising the quality of education if you're comparing it to an in-person training. And that's something that Dan just brought up. But I'm not talking about replacing in-person. I'm talking about supporting, supplementing, complementing, because as surgeons, we all know we will need in-person training. Other concerns are the lack of potential bonding or connection between educators and trainees. Believe me, that's the same challenge everyone was saying about telemedicine. You just need to learn how to bond with the other person on the other side of that monitor. And for some, it's the perception that these technologies, that virtual reality, that the robots will overtake our jobs. Once again, they're not here to replace us. It's accessibility, it's bandwidth. Not everyone has the bandwidth, for example, for very high-end solutions for teleeducation. And in these places where it's very cost prohibitive, you have to do proper return on investment analysis for these new training programs. And there's clearly insufficient funding and partnership opportunities yet to expand. So that's why I'm so excited about being part of this program, because I am seeing here so much synergy, so many institutions, so many people willing to partner. So in order to conclude, COVID-19 has clearly highlighted the possibilities for technological advancements within medicine and medical education overall. It's been more than 30 years, in some cases, of innovation that was actually brought into, in some cases, 3 months, over a span of 2 years, that have really skyrocketed everything that we're able to do today compared to just some time ago. But you do need global partnerships in order to be able to address that everyone has the fact or the possibility of access in an equitable way. So just a reminder, and to recap, our takeaways today are that the emerging technologies will actually help us train surgeons regardless of where they are in a very rapid way. They actually help us accelerate our learning curve in a risk-free environment. And the hands-on skill transfer of the cognitive and the psychomotor surgical competencies have an unlimited time or number of trial and error sessions. And they're all occurring on multimedia platform, which make it so much easier to engage with. So once again, gaming the micro-learning approach is something we should have in mind, specifically tied to very clear KPIs, using those artificial intelligence and using all the metrics, solution tools that we have today. It will help us continue to improve the outcomes of our curricula. So hopefully in the future, our next meetings will maybe be in metaverse. So this is just a dear thank you to everyone that's been with us today, and to these people that have somehow also inspired me and helped me continue in this new era of ICTs, not only for seeing our patients, but also being able to educate them. Thank you so much.
Dr. Ricord, thank you very much for that inspirational talk. There is much more that is to be done in this realm, and listening to your microwave story, I think it really is inspirational that we can take something from nothing and make it so big. So thank you for that inspiration. We're going to go forward to Dr. Roger Zaldivar. Dr. Roger Zaldivar is based out of Buenos Aires, Argentina, and a dear